Welcome to Quad A Now, where we explore the world of patient safety, the impact of accreditation, and other topics relevant to outpatient healthcare facilities and dental practices. Join us as we explore diverse topics, share success stories, and navigate the challenges that define the pursuit of excellence in patient safety.
Hi, I'm Tom Terranova, CEO at Quad A. Welcome to the inaugural episode of Quad A Now, a global accreditation podcast. For those of you who are not familiar with Quad A, we're a global nonprofit accreditation organization based near Chicago. Our mission is to assess medical facilities for safety and quality. We do this in order to promote best practices and improve the efficiency, effectiveness, and consistency of the centers we survey to promote patient safety. Our motto is patients first, always. And we've launched this podcast in order to provide regular communication to healthcare professionals, patients, and the public about topics that are important to protecting patients, improving healthcare, and hopefully improving practices in a way that benefits medical professionals, their staff, and the people they serve. Today, I'm joined by Dr. Bill Rosenblatt, Dr. Larry Reed, and Dr. Robert Singer. These three gentlemen are all plastic surgeons in private practice, Dr. Singer in California and Dr. Rosenblatt and Reed in New York. We've invited today's guests to kick us off with a conversation about Quad A, its origins, its purpose, and its impact, so that we can build upon that common knowledge and perspective in future episodes. So each of you was already in practice at the time that Quad A was founded. I would like to ask you guys to take us back to the late 70s and talk a little bit about the practice of medicine at the time, the shift to ambulatory surgery, and how that resulted in the creation of Quad A. Dr. Singer, I know you've written articles about this topic, so let's start with you.
Well, let's go back a little earlier than that. In the early 1900s, cosmetic surgical procedures were being performed, but they weren't done in the hospital. They were often done in hotels, back office, back alley offices, and with no oversight. In California, office-based surgery actually was fairly popular in the late 60s and 70s. And realizing that there was no formal oversight, plastic surgeons in ASPRS, which is now ASPS, in 1977, saw the need to establish an accrediting program and established a committee to establish standards for single specialty ambulatory surgical centers by surgeons who are board certified in plastic surgery. And at the point, it was quadruple PSF, with P being plastic. A board was appointed, and executive director, Ed Steiger. It was initially a voluntary accreditation program designed to educate plastic surgeons on safety, and eventually became the gold standard of accreditation. Inspections began in 1979. At that point, none of the other accrediting organizations of surgical facilities inspected office-based surgical facilities. So we were the first to do that. And today, the majority of all surgical procedures are performed in non-hospital settings. We'll let the area of morphing into a more global accrediting agency to something a little bit later. But initially, the inspections that began in 1979 were voluntary. As early as 1983, 80% of practicing plastic surgeons performed surgery primarily in office-based settings. And I was instrumental in having both ASPRS and ASAPS eventually mandate that its members operate only in accredited or licensed facilities, which was a huge step forward in safety for patients and for plastic surgery. And numerous studies have documented safety of operating in accredited Quad A facilities. And Quad A played a significant role and will continue to do that in producing better, safe environments for patients. The initial first president was Dr. Ed Trupman from Florida, and subsequently Gus Colon from Louisiana. And a number of the prior presidents of ASAPS became president of Quad A, as well as Ron Iverson, who was a prior president of ASPS. Interestingly, the first four presidents of Quad A, PSF / quadruple A, SF, were also at some point president of ASAPS. And 7 of the 13 presidents of ASAPS, ASERF, or both. And all of the quadruple A presidents were members of the Aesthetic Society. The first ambulatory surgical symposium to teach this and teach safety was scheduled in coordination with the Aesthetic Society meeting in 1981, and subsequently educational teaching courses were given at the various plastic surgery societies following that.
So it's really interesting, sort of the origin of the organization. And I was wondering, so like Dr. Reed, Dr. Rosenblatt, I know you were all practicing at the same time. And, we're firsthand witnesses to the dynamics at play in operating. And I know in speaking to some prior presidents, they said that was really the impetus was that, the dynamics in the hospital and moving into your office with care was maybe not controversial, but was at least something that was sensitive. And so that led to the committee and led to the creation. So Dr. Reed, Dr. Rosenblatt, I'm wondering from either of your perspective, what your thoughts are on sort of the broad dynamics of the practice of medicine at the time and what brought it into the hospital and the creation of Quad A.
I started practice, and there were only a handful of surgical facilities in New York City. As Robert alluded to, many were operating in hotels and really decrepit-looking places. But I was thinking of practicing in California, and they were way ahead of us in terms of the quality of their offices. I remember John Williams' office in Century City was absolutely amazing. Robert, do you remember the name of the ENT doctor who's very successful of Schwab's drugstore? Very famous aesthetic surgeon.
No, don't recall that. I know John Williams' facility. I was there several times, and that was the prototype of a lot of the office-based surgery in LA. And there was one fellow in Westlake Village who had an absolutely spectacular office, 5,500 square feet private building on the lake, and I was going to join him. And so they were really spectacular. And I realized there's a way to do this that doesn't exist in New York City yet. And no one had gotten to that level at that time. It was just starting. And many people were operating in really what I would call second-rate and inherently dangerous facilities at that time. But as Bob said, they weren't doing cosmetic surgery much in the hospital. So they had to do it someplace.
Well, I started in 79, and there were no controls. And I had a little operating room in my office, and you did a lot of stuff in it. And there were no regulations and there were no rules. The first group that made a regulation was the Plastic Surgical Society that said, if you want to be a member of the Plastic Surgical Society and you're operating outside of a hospital, you have to operate in a certified OR. So I got the book and I looked and I made sure that what I did in my place fulfilled all of this stuff. Later on, it came in that not only was it the National Society that required you to be certified, but the states started to approve that too. And why did they do it? Because there were deaths. There were problems. That people were operating in places where they shouldn't. They didn't have the right equipment. They didn't have resuscitation equipment. They didn't know what to do if the patient had a problem. They just said, hey, it's cosmetic surgery. How bad could it be? Well, it could be pretty bad sometimes. So at that point, regulations started to come around. So Larry, why don't you continue before I talk about New York State?
Let me jump in before Larry does that, because you mentioned the mandating that plastic surgeons who were members of ASPS or ASAPS could only operate in facilities that were accredited by national accrediting organizations or licensed. I'm pretty familiar with that because I initially introduced that concept in 1999 to COPSO. At that point, that was a Council of Plastic Surgical Organizations. And eventually I brought it to the board of ASAPS and ASPS, suggesting that it will improve patient care, it will enhance the image of the organizations, and that plastic surgery be the first group to do that. Well, eventually the boards agreed to do that and mandated that. But it was interesting because initially there was some pushback from some members of the board of ASPS who said, well, if we do that and mandate that, we may lose some of our members. And I said, do you really want a member who's going to be operating in a facility that can't meet minimal standards of safety? They finally agreed to that. And then they instituted that, and they required compliance by July of 2002, which dramatically changed the approach of cosmetic surgery.
Yeah, it's interesting that you both have talked about that, because I remember a conversation with another former president of Quad A several years ago, Dr. Harlan Pollack, and maybe he overstated it a little bit, but he recalled sort of the founding time period and said, when we were doing that and going to our office, some people looked at it as though it was borderline malpractice, but we couldn't really get on the hospital OR schedule. So, collectively we had to, show and decide to show and demonstrate that we could do things the right way and not in this sort of Wild West fashion. And that's really the mindset that brought around sort of the private regulation among the society or the societies of accredited plastic surgery facilities. So you both have alluded to the practices. Actually, all three of you have alluded to the practice mandates in your states, and you all work in two of the most regulated jurisdictions we have in the U.S., California and New York. So I wonder if you could just talk us through the evolution from Quad A being voluntary to one now that might be required by law or guideline or mandate, not just by your society, but by the government in your state or in your jurisdiction, even some foreign jurisdictions. So Dr. Singer, you sort of mentioned that California was first to post here. So maybe if we could start with you, sort of what took us from voluntary to a legal mandate in California.
Could I just mention one thing
Sure,
first,
absolutely.
Tom? I think a lot of credit goes to Ed Trupman, because there was amazing pushback at the beginning. No one wanted this. No one wanted their colleagues telling them how to practice medicine, coming to their offices. And Ed, it took someone with his determination and strength of character, and Gus Cologne to a large degree, who had the courage and strength because there was amazing pushback from credible plastic surgeons who didn't want people overseeing how they did their practice. And so
you're absolutely right, Larry. And actually, Gus, Ed Trupman, and I started doing office practice management educational courses at the Aesthetic Society in the early 1980s.
So without the three, then Robert and Ed and Gus, it really wouldn't have happened, because it took strength of character, because your colleagues were angry with you. And I was brought on as a young guy because I figured, well, he can't lose anything if something goes against him. Because you had to be out there fighting against people you respected who really didn't want this to happen.
Well, nobody likes regulations. And, here we were putting in a bunch of big regulations. And what happened in New York State was the health commissioner in New York State put together a meeting of physicians and all sorts of physicians, plastic surgeons, GI, general surgery, and whatnot. It's before 2009 was when it finally went into law. However, they had actually had some regulations before, but the regulations before were under legal assault by the nurse anesthetists who didn't like it. And in New York State, the Commissioner of Health said, I don't want to read in the Daily Post or the news, whatever paper it was, about another death in a doctor's office. So we all got together and discussed what to do. And in New York State, we changed this from a plastic surgical issue, and our definition was related to anesthesia. So in New York State, anything that was done under any form of anesthesia other than local, the facility had to be accredited. And which accrediting agency did it? We left that to the Department of Health. And in New York State, they picked all three. So that's how it went in New York State. And actually, that got Quad A to change its name from the Association of Accreditation for Ambulatory Plastic Surgical Facilities, and it was more generic to surgical facilities.
Bill, if I can add something to that, I attended those meetings that took place. As you said, the law was passed in July 14, 2009. And I was at the meeting, and this is if you saw the film A Bronx Tale when Charles Pimenteri says, "Now you can't leave." He locks the door and they can't get out. Jeffrey Keyes presented at that time, I think it was about 5 million cases, data we had on 5 million cases, and there wasn't a sound in the room. And that was the single most pivotal moment in changing their mind. He gave this presentation, not what I think, but here's our data. 1 in 60,000, 1 death in 60,000 cases, rate of infection 0.9%. He went on and on and on and on. And there was not one rebuttal to his data.
Well, you all raise an interesting point, and I want to go back to Dr. Singer for a moment, to California, because interestingly, when we talk about the data, we'll talk about it, I think, in a second, but, the data collection was certainly a pivotal change that really quantified the safety, I think, that the facilities achieved through Quad A accreditation and compliance, and really just sort of, kind of keeping an eye on all their practices. But to my knowledge, the mandate passing in California really predated the data. So I think there was a different dynamic there that happened compared to New York and some other states that adopted after we had, hundreds of thousands or millions of pieces of data. So I'm curious as to what your experience was as the mandate rolled through in California as the first state in the union to require accreditation for office surgery.
California, there were a number of high-profile disasters that were in the media, and that stimulated the medical board to look at development of something better. So we testified to the medical board in 1990. In 1995, it was passed, and that required that individuals operating and providing anesthesia did it in an accredited or licensed facility from one of the national organizations. Unfortunately, even today, 27 states don't require any oversight and accreditation, to me, which is a shame. The medical board subsequently continued to consult with Quad A to modify their regulations. And some of the other regulations that we were instrumental in with California under Jim Yates was we developed the guidelines for less than a 24-hour stay in the facility, and California subsequently adopted those standards for their own. So we were the leader in that. As far as the data that was presented in New York, which made all the difference in the world, in 2001, and I established the Quad A Educational Foundation, which was a step forward in improvement of safety and education. And I had asked Jeff Keyes earlier to develop that database system, which he did. And we had, in 2001, had a joint meeting. I co-chaired it with the executive director of the College of Surgeons. And we had over 30 different organizations involved in that. First time anything was brought together like that for safety. And because of the data that Jeff presented, they were blown away. And it established Quad A as the gold standard at that point, because nobody else had that kind of data. And interesting, we offered this to join into the data collection with the other accrediting agencies, but they chose not to do that. So we were the only ones who had the data, and it proved to be extremely worthwhile in all of the other states that were looking at accreditation. And it also was significant for CMS to have Quad A appointed as a entity that could do inspections for Medicare.
I mean, just to echo what you're saying, even today, the only organization that collects data is us.
Yes.
We collect data. And as a matter of fact, Dr. Lim, with his Harvard group, has another paper that's been published, and I'm presenting it next week out in Salt Lake City, and it talks about how nobody has a large number of ambulatory surgical problems or data regarding that. We do. And our data shows that it's incredibly safe in Quad A facilities to have surgery. And that's because of what we require our facilities. And now in New York, we've expanded. Obviously, it's not just plastic surgeons. It's gastroenterologists. It's pain management folks. It's the
interventionists, GI.
Right. The guys who are cleaning out shunts. I mean, anybody who does anything in their office under any form of anesthesia other than local has to be certified, or they can have their license pulled immediately.
So it's interesting that you guys bring this up, because we obviously live in an era of big data, and I think Quad A was really a standard bearer here, and it's because of the foresight of our board and Dr. Singer and Dr. Keys and the presidencies in the late 90s and early part of 2000s, because the data creation, the data collection really goes back to 2001. And, I don't want to get into the details of the elements of data that are collection of the structure, but you all are doctors, you go to medical meetings, you go to these regulatory meetings, and you have a chance to see how this data contributes to the practice of medicine. So I know a number of studies have been written from the data that's been collected from Quad A facilities. And I wonder if you can speak to how the data actually contributes to medicine and to safety, rather than just what it means in terms of compliance and what it means for the regulators, but what does it mean for the practice of medicine and what it does for your facility?
Well, data is king. If you have the data, then you can look at where are the areas of problems and make either research through things like ASERF or institute other things that will help prevent problems. The data that Larry referred to, and we have a lot more data since then. And part of the reason we have that data is required that every individual who has an accredited facility report untoward events. So we have that. And in 2013, it was reported that we had over 7,600,000 procedures on over 5,400,000 patients, which included 5.525 million plastic procedures on 3,920,000 patients. And the mortality rate was 0.002. Infection rate was very low. And it was shown that complication and infection rate was actually lower in an accredited Quad A facility than it was in the hospital. It was more cost effective. It was more private. You weren't bumped by other cases. There weren't dirty cases that went before you. So it also provided greater privacy and comfort for the patients, as well as the important thing is we could show that it was safer.
Also, with the data, we were able to pick up trends. The prevalence of VTE as a complication after surgery, that was documented. I remember Jeffrey Key's numbers on that. And we were able to alert our members and make them more aware and institute things, use the VT, Caprini sheets, etc. With the Brazilian butt lift more recently, when we saw a trend there, we made people more aware of it. We took positions on it. So I think that data helps us for our membership to give them some guides and what to do and what not to do and things to be careful about. So it's a very valuable service. And it's not based on anecdotal stories. It's based on the data that, Bob encouraged us to get many years ago.
Dr. Rosenblatt, you mentioned that you're presenting the case that you co-authored, or the data research that you co-authored with a group from Harvard. And I wonder if you could speak to how that really hopefully will impact the practice of medicine?
They basically looked at statistics from 2019 to 2021. So it's only 2 years, but there were still 250,000 cases, and there were only 984 complications, which is an overall complication rate of 0.4% and a mortality rate of 0.009. So it's very, very safe doing surgery in your office. And, these were numbers that we were able to get from our statistics. And again, there's no other certifying agency that has these statistics. And obviously, as we go on, we will get more and more numbers. And, our PSDR, or our collection of data, is just getting stronger and stronger as the years go on. And as we redo our system in the office, it's getting easier to compile these. And this is important because when a patient comes into your office and they say, well, how do I know it's safe doing it here? And you can show them how safe it is, because, doing stuff in a hospital is not without problems.
Bill, it's interesting that the death rate since the beginning of statistics, I remember the early number was 1 in 60,000 cases, which is 0.0016%. So it's really unchanged. That's been a very, very low number.
A wee bit lower, but yes, you're right. I mean, that's what it is. But, a lot of times the mortality rate, from our experience, has almost nothing to do with the surgery. It's an anesthesia death.
I disagree a little bit, because when you look at the deaths we see, for example, with the vascular interventionalists, that's not due to anesthesia. They are the sickest people in the world.
Absolutely.
So you have to, there's a whole, the GI guys deal with very old people, many are on blood thinners, but the interventionalists, they're all on end-stage renal failure. They have multiple comorbidities. They are the sickest population. So that's not really anesthesia related. A lot of these deaths are not unexpected. Can I say that?
You're right.
Those are interventional things, but within plastic surgery, we have to understand that not every patient is a candidate for office-based surgery. And a lot of what we've learned and through the data is allowed us to educate the surgeons more and educate the staff. And by educating the staff, and it comes from an organization like this, it's easier than if the surgeon says, we want to do it this way, and they say, why? Very different when we started Quad A from the other accrediting agencies is we didn't want some of the excess regulations that the hospitals had that had no basis for patient safety, that only made it more complicated. And I think we've stuck to that. And we've also continued to modify our requirements and our regulations as time goes on, as we've learned more. We also have on the board not only board certified plastic surgeons, we have other specialties. We also have, past presidents of ASA, the anesthesia group, and nurse anesthetists. So it's a much broader spectrum than when we first started with just plastic surgeons.
Well, it's an interesting point that you make, and that, sort of Dr. Reed picked up on from Dr. Rosenblatt's comments, is that though the origin of the organization was really in regards to plastic surgery offices, the accreditation is really comprehensive, and really relatively little of what we're looking at is intraoperative kind of surgical technique, surgical judgment. That's really not that's not the focus of accreditation. It's the operations of the facility. It's the procedures and protocols and equipment and all the infrastructure that's set up to allow the surgeon to succeed and to operate safely. And that relates to anesthesia and record keeping. And certainly I think there's bureaucracy involved there, but there's the practice of medicine that goes beyond just the plastic surgeon in the origin days. And now, I remember when I joined Quad A, 92% of the facilities practice plastic surgery. I think now it's about 40%. So we are a very different organization and under very different pressures than we were then. But certainly all of those procedural and infrastructure type of considerations go beyond just plastic surgery. I mean, wouldn't you agree?
I do. I examined a few weeks ago a large maxillofacial orthognathics group of doctors, oral surgeons in Long Island. They said they felt that Quad A being run by physicians, which has always been Dr. Singer's point, he always mentioned that was an important part of it, they felt comfortable with us and that we understood their needs as doctors. That we didn't overreact, we were proactive, we weren't gunning for them, we were trying to make them practice safer medicine. That's been Quad A's credo since the beginning. It's a doctor-run organization. We understand the needs of our clients, what's going on in their we practice ourselves, we're active in the practice. So I think it's very helpful for Quad A as well.
Very different from the bureaucracy of some other organizations, and that we come in as an educational tool for the inspections. It's not an adversarial group. The last thing I'd want to do is to have that type of mentality inspect an office-based facility. Not that it should be any less of an inspection. It still needs to be professional. It needs to follow all of the guidelines, and it needs to be 100% compliance with our guidelines, which we do.
So it's
I
interesting.
agree with you. Our role, I always said, was educational, first and foremost. Yep. Patient safety and educational for the doctors.
So it's interesting that you all have indicated two very clear differentiators. The data collection, to use your words, no one else collects it, and that no one else requires board certification and sort of scope integrity within their accreditation regimes. It seems like a very concerted effort to differentiate what Quad A does and how it does it from other organizations, and that was a concerted effort from the beginning. So, Dr. Reed, I'm wondering if you could, start us off talking about, what your thoughts on how the founding and early leaders of Quad A set the organization up to operate differently than other accrediting organizations, aside from the data and the board certification and scope requirement that we just talked about. What else in your mind makes it a different process than some of the academic and larger institution processes?
I think that from the outset, we've had, and I'm talking about the board now, not our executive staff, which is a separate topic. We have an amazing executive staff under your guardianship. But I think from the beginning, we've had exceptional leadership and exceptional presidents and really dedicated, committed board members. I think of all the presidents who you mentioned, Iverson and Jim Yates and Alan Gold and all these guys, Jeffrey Keyes and Mike McGuire, on and on. These were really top-notch leaders, each who brought their own input, but they had one thing in common. They cared about patient safety. These were really credible, committed guys. You're not getting paid to be there. You're there because you care about patient safety. And I think I'm always amazed. It's hard to find people to volunteer for. You can't find the young doctors who want to volunteer for anything today. They don't want to join anything. They want to practice. I understand that. But you can't find a volunteer group like we have in Quad A committed to patient safety, and they do it really because of passion. And that's in every level of our board. I mean, I couldn't be more proud of this board and Bob's work and everyone else, now Bill's work. This is the top leadership you can have committed to this safety issue.
It was interesting. It's a group who often thought out of the box. And if an issue came up, it wasn't so much, oh, here's why we can't do it. Put as much effort into thinking how to get it done. And that's what it did.
I agree. I mean, and look, we've duked it out on issues, and that's how it has to be. But the common goal was the same thing. There was no personal selfish interest as a rule. It was all about patient safety. So I can live with that any day of the week.
Let me give you an anecdote that's of how far we've come and the lack of the ability of, quote, government to do anything initially. In 1989, Dr. Trupman, Cologne, Ed Steiger was the executive director, and I were invited and testified in a hearing before the U.S. Congress Subcommittee on Regulation of Business Opportunities and Energy, and a subcommittee, that was a subcommittee of small business. It was chaired by Ron Wyden. And it addressed cosmetic surgery, procedures, standards, quality, and certification of non-hospital operating rooms. We recommended to Congress and to that group at that time that they develop national standards covering both office space surgical facilities and the surgeons who practiced in them. We suggested peer review for physicians practicing in facilities, and ensure truth in advertising by requiring full disclosure of the physician's training and limiting claims of board certification to those physicians certified by boards recognized by the American Board of Medical Specialties. And in addition, doctors claiming board certification should be required to state the full name of the board that they were certified by. So it was a lot of publicity. Wyden's group got a lot of media attention, and nothing came of that. They decided not to do anything. So it was up to us taking it to state boards to get anything done. It could have been much safer and much better if it had been instituted years ago by the government after we tested.
We have the same thing in New York. We talk to the Department of Health and we say, let's have a truth in advertising. If you say you're board certified, show what board you're certified by. You know, if you say you're a plastic surgeon and you're certified by the American Board of General Surgery, you're not a real plastic surgeon. So we try to get that. It gets thrown out. I mean, it's always a power struggle between different specialties. And the only good thing is you know that if you're certified by Quad A, the person that you go to is what they say they are.
Well, you know, I think it's something that's worth mentioning is I think the integrity of the Quad A system since the founding has really been important, as you've said. You've all touched on the patient's first aspect, the patient safety aspect, the education aspect. We've talked about data. We've talked about board certification. Right. You know, I think earlier on, one of you mentioned 100% compliance mandate. To my knowledge, Quad A is the only organization that requires facilities to submit evidence that they've actually carried through corrective actions. Every other organization, to my knowledge, actually just confers accreditation based on a plan of corrective action rather than actually evidence that it's been completed. And so it seems to me that reliance on data has freed, at least to some extent, Quad A up from some of the more political battles that are not necessarily based in data. And it has allowed Quad A to up its standards, to revise its standards, and to move forward based on data and science and human physiology rather than sort of political battles. And I think the organization under yours and your colleagues' leaderships has really sort of lived that sort of ethos to stay in that sort of pure safety lane. So, you know, as you've set up to be different and really be educated and really stay in the safety lane and work through these mandates, it's really brought the organization into contact with a lot of folks, not just plastic surgeons, right? Now, as you mentioned, we're in a lot of other organizations and dealing with a lot of other specialties. Dr. Rosenblatt, I wonder if you talk about how this has contributed to a difference in the number, the type, the complexity of the facilities that Quad A accredits, both in private practice and, you know, the multiple Medicare approved programs that the organization has. What are your perspectives on this shift as an organization from something that was to something that it is today?
Well, I mean, there was no requirement that a facility be certified. So I think that it's a major shift to require it. And a lot of different facilities use anesthesia. And I think it's very important that they be inspected and certified for safety, because we want them to have the appropriate drugs, the appropriate equipment, the appropriate procedures in order to safely operate on our patients. So I think that it's absolutely imperative to have an organization such as Quad A.
You know, although we inspect, you know, obviously many things beyond plastic surgery, part of the impetus of extending it beyond plastic surgery many, many years ago was because there were physicians from other specialties who wanted to use their plastic surgical facilities. It was convenient, it was less expensive, and part of our impetus to change it to quadruple ASF and drop the P was to accommodate those other specialties. And then other specialties wanted to come in, not just the physicians working in those offices.
So they were bunking up with the plastic surgery colleagues, and the standards had to reflect all those specialties that were coming into the same environment.
Yes, and I think another thing that's important for those who are not totally familiar with Quad A is that we have different levels of accreditation depending on levels of anesthesia. It's not a one size fits all.
Right. You mentioned that there was really kind of nothing before, and there's a level of assurance now where accreditation exists. And Dr. Singer, you talked about the fact that that there are 27 states that really don't still have anything on the books. The organization did a lot of research, blind research through some research associates and affiliates, and found that fully 35% of patients, their primary concern was the quality and safety of the care that they would get going to a non-hospital setting, because they didn't want something to go wrong. And a further 25% of patients were worried perhaps that this office surgery setting wouldn't have the emergency drugs, equipment, processes to save them if, God forbid, something did go wrong. So you can see that that's a huge underlying concern among patients, and yet there's still a vast open ocean where there's not really a requirement, and there's not really anyone speaking to that concern and how to correct it. So clearly that's the role of Quad A in an accreditation organization like this. What would you say probably is the key to kind of meeting that unmet need that patients have, where they're worried that something might go wrong, and if something goes wrong, an office center isn't set up to save me?
I'll tell you one thing that's happened, Tom, is that I know in New York State and New York City specifically in local areas that the arch enemy of outpatient surgery at the beginning was the American Hospital Association and the New York hospitals. They really resented it, and they felt that it wasn't safe and you should be done in a hospital. Now, the current paradigm for businesses, they all are downsizing their beds when they rebuild and opening up major outpatient facilities. Bill, have you ever been to Marcus Avenue in Late Success for inspections?
Yeah, I know what they're doing there.
It's miles and miles of outpatient facilities run by Mount Sinai, Stony Brook, Northwell, New York Presbyterian, etc. This is a new paradigm for business. HSS, the major orthopedic surgeons, they now do outpatient, same day, total hips, total knees, etc. You come in and go out. Now, they're being done in more sophisticated centers, but they're also outpatient centers too. It's the way medicine is being practiced today. And really, we're kind of on the ground floor of this.
Well, one of the main things here is cost. And a lot of patients, when they come into your office, they want to know about cost. And one of the things that we see is that a physician's office can usually keep the cost lower than a hospital's ambulatory surgery center. But we just have to make sure that the physician's office is as safe as the hospital.
We can keep the cost down without being able to group purchase the way hospitals do and still keep the cost down for the patients. Think about that.
And the vast majority of surgery across the country today is done on an ambulatory basis, and the vast majority is done outside of the hospital. It's interesting when patients come in, their primary concern should be safety. And I find that it's also, a marketing benefit to have an accredited Quad A facility, the gold standard. And we talk about that. We can show them the facility, and we point out what it means to have accreditation and what the record of accreditation is. And I see patients from other states and out of the country, and they come in and I say, why would you possibly go to a facility that doesn't meet these reasonable standards? And usually that's fairly convincing to them. On that level, we also, I don't know if you want to bridge into what we're doing internationally, but we've brought that to, and we've been worked with Renato Saltz and with Fawad Nahai, with Alberto Arguello and ISAPS to bring accreditation on an international basis to ISAPS, because the vast majority of facilities out of the country, although there may be excellent facilities, they don't have any oversight. And some countries do, but most don't. So we've tried to work with them. And that also improves the overall, raises the bar of the image of plastic surgery internationally. Because if there's a problem in any country, we're all painted with that same brush.
Absolutely. They don't distinguish. One thing is that Bill Rosenblatt, during his presidency, introduced, and which I had always said was most important, is the need to make the public aware, to use public relations and social media to make everyone aware of what Quad A really did, because the public really doesn't know that much about it. They don't know much about accreditation. I know that Tom and Randy's working on that and under Bill's aegis, and I think that's a very important step forward. We have to let the public know the value of an accredited facility. I think we're heading in that direction. Am I correct?
Yes. Yeah, definitely.
That's a very important step. We know it, but the public still is not as. My patients really aren't that aware of it until I tell them about it.
Well, Dr. Singer brought up a great point. Earlier, you mentioned Mike McGuire, and Mike McGuire, I think, was the president when the international program was really formally launched. I think it was 2005. And since then, Quad A's worked in 20 countries. We're active in 14 right now. Some of them have mandates, others don't. In my opinion, whether there's a local regulatory regime or not, Quad A plays a valuable role because, one, it establishes consistency country to country to country. Because as you've all articulated, sometimes regulation is in direct response to some sort of crisis. And so it might be highly specialized or highly reactive to that crisis. Whereas our process is very scientific, a little bit more third party and dispassionate and arm's length, and provides consistency so that we can supplement where facilities might be highly regulated. But then in those countries where facilities are not regulated at all, we can provide that sort of safety net. So Dr. Rosenblatt, you can speak to this, I think, as well as anybody, but the efforts to move into the global space as the world becomes smaller and patients find it easier and easier to travel, to seek care wherever they want, but to take safety out of the equation by making it a given. So I know that's a big push of Quad A's now, and certainly you're a big part of that. So I wonder if you would offer your perspective.
Well, it's just that we are working. We have facilities in Dubai and representatives in that neck of the woods, and physicians in Central America, and offices that are certified basically all across the world. So we're looking to continue to expand our certification of office operating rooms, whether they're here or elsewhere.
One of the important things to realize, things are different in different countries. I will be very pleased if we ever got to the point that accreditation was mandated internationally. And we're working on it.
I think we all would. I think I've become fond of saying an airway is an airway, no matter where in the world it's compromised. So, those safety standards are important across all borders. The approach might be different, as you said, country to country, but, science is sort of the same in terms of who and how a patient responds to medical stimuli, right?
I also think that Quad A has been very responsive to the changing face of medicine in this country. We recognize that not all doctors join hospitals anymore, as long as they make arrangements to be covered in their hospital, which we allow for that. So we have really been responsible to the changing face of medicine in this country. In rural America, many doctors can join the hospitals unless for various reasons, but we allow them to practice under the guidelines we set forth, the mandates we set forth. I think that's a credit to Quad A as well.
Accreditation and safety is in everybody's best interest.
Absolutely.
I think all of that is a credit to the three of you and your colleagues and the rest of the Quad A's past leadership and current leadership. So I think Dr. Singer, as usual, you put it in a really good, concise manner. I want to offer you all and ask you all if you have any important parting words for our listeners that we haven't covered yet before we finish up. Dr. Singer, I'll start with you since you're the first one on my screen.
I have believed in accreditation and safety since I started practice. The things that I've accomplished, those things in safety are the things that I hold the highest to emotionally of accomplishments. And, we couldn't do any of this without the great staff that we have at Quad A, who are reasonable, not excessively bureaucratic, and respond on a very quick basis to questions that come from outside. And I tell everybody, the only bad questions you have are the ones you don't ask. So you can always go to our central office, a call, and they're responsive, and we'll try to make it easy for anybody who's coming in and would like accreditation, or those who are accredited and still have questions.
Thank you. Dr. Reed, any parting thoughts from you?
No, I think that we as physicians have a sacred responsibility to ensure patient safety in our facilities. And I think most doctors who practice feel that way as well. But I think I've changed the way I practice through the mandates of Quad A as well. You have to keep changing and advancing. So it's good to have someone there to keep you up what's currently happening, what's safe for your patients. And we provide that service not only to ourselves, but to our clients as well.
Thank you. Dr. Rosenblatt, as the current sitting president for Quad A, I'll give you the final word.
Well, the most important thing from my point of view is think about your spouse, your child, your loved one. If they're having surgery in an office-based setting, you want them to be safe. And that's what we try to make sure happens. We want everybody to walk in, have their surgery, and leave and not have an issue. So safety is our main goal. Thank you.
I want to thank our guests, Dr. Bill Rosenblatt, Dr. Larry Reed, and Dr. Robert Singer for being part of our podcast. I'm sure everyone enjoyed hearing your perspective on the origins and development of Quad A and its important mission. I know I'm excited to build on our discussion today with topics that will carry accredited centers and Quad A into the future. And thanks to our listeners for tuning in. Remember to join us next time for further insights into accreditation and the importance of patient safety. Until then, stay informed, stay safe, and we'll see you soon.
That's a wrap on another enlightening episode of Quad A Now, a global accreditation podcast. Stay tuned for more captivating discussions with leaders who are shaping the landscape of quality and patient safety. Remember, patients first, always.